So welcome everybody to the very first collaboration between the IOA PG Teaching Committee and the Wadia Children's Hospital Department of Pediatric Orthopaedics. It is my pleasure to have Dr. Shiva Shankar, our very, very versatile and innovative man in trauma, as he's known as, to give us the inaugural address. And Dr. Rajgopalan Iyer also here with us, who is one of the sweetest, gentlest persons I've known, besides being a very, very well achieved and huge contribution to St. John's as well as Pondicherry. So without much ado, I request our IOA President, Dr. Shiva Shankar sir, please give us a welcome address.
Good evening, everyone. I welcome all, especially the PG students attending from across the globe. I welcome all of you for this today's IOA Wadia Children's Hospital combined webinar by Dr. Sanjeev Sabharwal, who is the Deputy Editor of JBJS and POSNA, who has joined from San Francisco, California, USA. At the outset, I declare this academic activity open. I would like to congratulate the Department of Pediatric Orthopaedics, BJ Wadia Children's Hospital, who are a proud recipient of 2020-2021 Robert Bucholz Journal Club grant from the JBJS Resident Education Fund. This today's activity is a collaborative effort of Wadia Children's Hospital with Indian Orthopaedic Association. There will be 3 webinars in this series named the Fundamental Teaching Series, IOA PG Teaching and Wadia Children's Hospital Collaboration. This will be essentially involving invited guest talks from the editors of JBJS panel who share their knowledge and experiences on aspects of PG training not covered so far in the IOA schedule. This would be held monthly for next 2 months, total 3 months, and it would be held on a Saturday late evening in the month of March, April, and May, like today. We already have today Dr. Sanjeev Sabharwal, who is the Deputy Editor of JBJS and Pediatric Orthopaedic Society of North America, POSNA. He will be talking on angular deformity correction in children, and he will be discussing in detail the planning and various methods of treatment available, including growth modulation, physial bar resection, etc., and various osteotomy. I welcome Dr. Sanjeev Sabharwal for this today's webinar. Friends, the next webinar in the month of April will be by Dr. Mark Swintowski, who is the editor-in-chief of JBJS, who will be talking about how to plan a study and get it published in JBJS, and he will cover extensively how to run an effective journal club, how to critically evaluate scientific literature, the current literature available, how to plan a research study and write manuscript and get it published. And the last in the series will be by Dr. Kishore Malpuri, who is from British Canada Children's Hospital and Research Institute, and grand rounds with Canadian Orthopaedic Association he will be taking you through. His topic will be how to write a research grant and participate in international registries, tips for writing and compelling research grant proposal, how to participate in international research collaboration, etc. Friends, I welcome you all for this today's webinar in this first in the series. I once again congratulate Dr. N. Rajgopalan, Chairman of PG Teaching Committee of Indian Orthopaedic Association, for this initiative, and my sincere thanks to Dr. Rujuta Mehta and Dr. Alaric Aroojis for coordinating this along with IOA for wider reach. I once again thank all of you for having me here for this short inaugural session. I once again declare this open and Rujuta to take over and carry on. Thank you very much.
Thank you so much, sir. May I request Dr. Rajgopal to just give us a very quick blessing, and we then start with Sanjeev, who is a huge doyen in the field of lower limb deformities, to give us his talk. Dr. Rajgopal, sir, would you like to say something?
Yeah, sure. 1 minute, just adjusting the thing. Good evening to you all. It's a very great privilege for us from IOA and IOA PG Teaching Committee, and my thanks are due to Rujuta and Dr. Alaric I owe everything to them for having doing it along with us. And it's a great beginning. And we are very lucky today that the beginning is by Dr. Sanjeev Sabharwal, who is well known to all of us here who are interested in pediatric orthopedic, and a very useful topic, I will say, particularly for our postgraduates, because this is something very common, at least in this side of the south, and I'm sure we are all going to benefit from that. And I thank Dr. Shivshankar, our president, for permitting us to do this, and I thank Dr. Rujuta for taking all the trouble. I think I did nothing except saying yes, yes every time. Thank you all, and thank you very much, Dr. Sanjeev, for taking off your time. I know you are a very, very busy person, and we are really looking forward to hear from you. Thank you.
Thank you so much, Dr. Raj Gopal, and thank you, Dr. Shiv Shankar, President of IOA. It's really a privilege for us to associate with our parent body, IOA, to take this PG training forward. Ever since we knew that we had won this very prestigious award from JBJS, our first thought was to see how we can make this teaching program not just for our Wadia residents and trainees, but for PGs all across India. And thanks to support from our very dynamic IOA President, Dr. Shiv Shankar, and the PG Training Committee of IOA, Dr. Raj Gopalan, we are here today to welcome our very first speaker, who is Dr. Sanjeev Sabharwal. And it's a great honor for me to introduce our speaker to all of us. Many of you PGs have heard him before. You all have interacted with him at various conferences, but it behoves me to say a few words about Sanjeev. Sanjeev is a great friend of mine personally, but also a great friend of our Pediatric Orthopaedic Society of India, PORSI, and the Indian Orthopaedic Association. He is the Director of Orthopedics at the UCSF Benioff Children's Hospital in Oakland, California. Previously, he was the Chief and the Director at the Rutgers, New Jersey Medical College in New Jersey. Besides being the Deputy Editor of JBJS, he's, as I mentioned earlier, a great friend of PORSI, and he's one of the main facilitators of the PORSI-POSNA workshops under CORE, which is the Committee on Orthopedics for Underserved Regions, which was initiated under the leadership of Professor K. Wilkins, whom many of us know and admire. Right from 2006, Sanjeev has been facilitating these biannual workshops with PORSI, and we are almost on the 8th iteration of these workshops. The last was being conducted last year at PORSI. Unfortunately, it got cancelled because of the COVID pandemic. Sanjeev is a great limb reconstruction expert, and he has got some multiple papers on limb deformity analysis, planning, and treatment. And I'm sure all of you all have read his various publications on limb reconstruction, especially in Blount disease. Sanjeev also is a great teacher. He believes a lot in global outreach and bi-directional learning. And many of you, again, must have met him before and interacted at various conferences and have learned a lot from him. So I'm really glad to welcome my friend Sanjeev Sabharwal. And without much ado, Sanjeev, you have already shared your screen. So let's begin hearing your words of wisdom and a later interaction that we can have with the PGs and trainees on this important aspect, which is very common in our Indian subcontinent, basically lower limb angular deformities. Over to you, Sanjeev.
Thanks, Alaric, and thanks, everyone. Thanks again. I don't want to take up too much time, but really, it's a pleasure and an honor to be here with all my friends here and new friends from IOA and, of course, Wadia Hospital. And thank you all for inviting me. And I know people are going to be joining in, and this is being recorded. So hopefully, more people can listen in later. So yes, so my task today, as Alaric said, is to talk a bit about lower limb deformities. We'll just focus sort of at a PG trainee level in terms of, talk about causes, how to do deformity analysis, and then share some of the techniques that have been used and have evolved over the years. Okay, so very briefly, causes of lower limb deformities. And again, this starts with the very basic to figure out what's physiologic and what's pathologic when it comes to pediatric lower limbs. As we all know, children start with bow legs and then they move on to knock knees. And then that sort of plateaus to adult limb limb alignment around age 6 to 7 years. So I think one of the basic issues is to figure out what is not physiologic. And as you can see, there are many causes. So I think the first part of the talk, we'll just show some pictures and hit on all these different categories a little bit. So again, children are born bow-legged around age 1.5 or so, their legs are straight. By age 3 or so, 3 years, they sort of overshoot into knock knees or genu valgum, and that sort of plateaus to what's adult normal by age 7. And then beyond that, it stays a little bit of physiologic genu valgum. So what are the congenital causes? And again, these are not all of them. I'm just going to show you 1 or 2 examples for each through my practice. So this is a child with a congenitally short femur on the left side. And you can see they have multiple associated issues. A lot of them have hypoplastic or absent fibulas, and various issues with the leg itself, starting proximally with hip dysplasias, femoral retroversion, hypoplastic lateral femoral condyles, ACL, PCL deficiency, etc. Now, the congenital short femur also is a huge spectrum, from the milder case that's shown above to a more severe one here, with various stages of pseudoarthrosis of the proximal femur and more flexion deformities at the knees. Oops, sorry. Then, this again is a classic test question that comes up, like what kind of tibial bowing is associated with what anomalies? So, the 3 classic ones. First is anteromedial bowing, and anteromedial means that that's where the apex of the tibial deformity is. So as you can see in this child, he's got, absent lateral raise. The 2 lateral toes are missing, and you cannot see the fibula here either on the right side. So this is classic fibular hemimelia. So again, anteromedial tibial bowing is associated with fibular hemimelia. The anterolateral bowing is the one that sort of has the worst prognosis. Here you can see a child who's got cafe au lait spots, neurofibromatosis, and has a dystrophic distal tibial and fibular shaft. And so this is a bad prognostic sign. And he has, congenital pseudoarthrosis of the tibia, or I guess it's a pre-pseudoarthrotic condition. So a lot of these children need to be protected in a total contact orthosis. There's been recent papers on, guided growth helping these deformities as well. The third one, which is the least has the best prognosis, is a posteromedial tibial bow, often associated with a calcaneovalgus foot. And these tend to remodel to some extent, but not all of it. And again, their main issue long-term is a leg length difference. So again, the 3 types of tibial deformities I think are important to recognize. Congenital hyperextension of the knee is another congenital issue that's more soft tissues and comes in different grades of severity. And this could be associated with hip dysplasia. So that's another thing. If you see a child with congenital hyperextension of the knee, always screen their hips for hip dysplasia with ultrasound and other imaging. So those are the congenital causes. Developmental causes, the classic is, like Alaric mentioned, is Blount's disease, but there's many others, meaning that the child is not born with this problem, but develops in the growing years. Blount's can be early and late onset, depending on, age of onset before or after age 4 years. Oops. And again, they have classic radiographic features. We're not going to go into all the details, but I think getting a full length standing X-ray with the patella pointing forward is a good place to start. Sometimes you can have recurrent deformities, like in this child who was treated and then had recurrence, and further imaging shows a physeal bar that's developed across the medial portion of the proximal tibial growth plate. And of course, guided growth is not going to help in these cases. So you either need a physeal bar resection or some kind of a plateau elevation. Okay, somehow it stopped advancing here. Okay. Then you can have iatrogenic causes. So this was a child who was treated for Blount's disease, bilateral Blount's disease, right worse than left, with recurrent deformities, but then did not show up for follow-up. And you can see you've got worsening of the deformity on the right side and overcorrection on the left. So I think that's another message. When you're treating children for various disorders in their growing years, close follow-up, at least to skeletal maturity, is crucial. This is a condition that's seen more often now. It's almost the reverse of Blount's, where instead of having varus, you can have valgus deformities in these heavy children. And the valgus in children or adults also with large thighs is not well tolerated. And there's conjecture that this may be related to, increased pressure, axial pressure over the lateral aspect of the growth plate of the distal femur, which causes, relative undergrowth on the lateral side, causing, valgus deformities. So some post-traumatic causes. This is a Cosen's phenomenon, which I think most of us recognize. It's often seen in toddlers or the 3 to 4 year olds that have a relatively benign undisplaced proximal tibial metaphyseal fracture. And over time, over a few months, they can develop pretty impressive valgus from the proximal tibia. Some of it will remodel, but I think the importance here is to inform the family that this can develop right at the outset. So this is another cause of angular deformities in a child with a physeal injury to the distal femur. And this is quite common in terms of developing a post-traumatic deformity. This child here was treated elsewhere and had a Salter 2 fracture that was treated with delayed open reduction and pinning, and then developed subtle changes in the lateral aspect of the distal femoral growth plate, and then went on to develop patellar instability. Here's another patient with more of a sagittal fracture line, and was treated with close reduction and pinning, then was lost to follow-up, and then came back several years later with a growth arrest and an apex anterior or a procurvatum deformity of the distal femur. So the point again is you have to see these children over their growing years. Just because a fracture has healed doesn't mean that the game's over. So the importance of follow-up. Here's another child with a road rash and obviously a mid-shaft comminuted tibia fracture that was treated with external fixation. But what's not apparent on the X-ray and can be seen on the clinical X-ray is this sort of perichondrial injury to the distal tibia. And this child's tibia shaft fracture healed nicely, except that she developed a growth arrest with a varus deformity related to the distal tibial physeal bar. So again, and sometimes getting the opposite contralateral X-ray and other advanced imaging helps in order to better define what the issue is in terms of a deformity. Oops, sorry, something happened here. Okay, can you see my screen again? Okay.
Yes, Sanjeev.
Yeah.
Okay, good. Okay, great. I'm sorry, I don't know what this happened here. Okay. Here's a child, actually not a child, an adult who had a childhood injury, a femur fracture that was treated with tibial traction. And she came in and was actually referred by one of the sports surgeons saying that, she may have, she initially came for perhaps a PCL injury, but in fact, what she had was a growth arrest related to perhaps a tibial traction pin causing injury to the anterior aspect of the proximal tibial apophysis. And over the years, she developed this recurvatum deformity of the proximal tibia. So I think for trainees, when you're putting these tibial traction pins in children, you just have to be aware of the close proximity of the growth plate, especially anteriorly of the proximal tibial physis. Okay, and then, unfortunately, I think all over the world, we do see children with non-accidental trauma or child abuse. This unfortunate child had third-degree burns related to child abuse. And that in itself can cause multiple deformities, not just in the skeletal system, but also in the soft tissues, as you can see here. Then infection is a common cause, and I think you know this better than I do, that how many times missed opportunity with musculoskeletal sepsis, in this case, was an untreated septic arthritis of the hip that then traveled distally. This child had a pathologic fracture and then developed growth arrest distally in the femur. So I think if this was treated early on with urgent washouts of the hip sepsis, a lot of these issues may have been avoided. You can similarly see another sequelae of a septic arthritis of the hip in this older patient who developed growth arrest and abnormalities of the proximal femur related to childhood sepsis of the hip. So metabolic causes, rickets again is a common cause. You can see in this patient with excessive genu valgum, left worse than right, and then typical physeal changes with widening of the growth plates all over, and cupping of the metaphysis consistent with rickets. Osteogenesis imperfecta is another cause of skeletal deformities. Neuromuscular causes, like we know, arthrogryposis and cerebral palsy are some of these other causes of deformities. Skeletal dysplasias. This is a child who has focal fibrocartilaginous dysplasia, which can be mistaken for other causes such as Blount's disease, but it has a very classic sort of punched-in lesion on the X-rays. And thankfully, these do resolve over time. And typically, they can be seen in the proximal tibia and the distal femur metaphysis. Achondroplasia has classic features clinically, including a trident hand and rhizomelic shortening. This is a child with metaphyseal chondrodysplasia, which is a form of bone dysplasia, as we know. And often this can be confused with rickets, just because you can also have these metaphyseal changes. But again, these children look a little different, and it is in the differential. So you can get metabolic blood work, and that'll be pretty much normal in these patients. So that's a differential for rickets. Multiple epiphyseal dysplasia is another cause of limb deformities. And you can see this patient has, narrowed epiphysis all over, including the proximal and distal femur, as well as the tibia. And the classic in training or the exam question here is, how is this different from Perthes at the hips? And often people say that in MED, the epiphyseal changes are pretty symmetric compared to a patient with bilateral Perthes. Multiple hereditary osteochondroma is another cause of limb deformities, where it's pretty obvious that they have these multiple osteochondromas that can cause injury or changes in the growth rate, causing angular deformities, typically around the knees and ankles. And finally, you can have things like multiple enchondromatosis, such as Olliers disease, which is associated with these classic findings on X-rays and can have limb deformities as well as shortening. One last sort of bone dysplasia is McCune-Albright syndrome, which is a form of, which is a combination of polyostotic fibrous dysplasia, often with some skin changes on one side of the body and some endocrinopathies. So again, I think the point here is there's such a spectrum of limb deformities and the causes for it that you just have to keep your mind open and look at the big picture before you start treating these limb deformities and saying, well, this is what needs to be done, because natural history is important, and to recognize what could be associated with it. Okay, so moving on to the next section, which is the clinical and radiographic evaluation. And again, always think three-dimensionally, although for the most part, just like with scoliosis, traditionally we just look from the front or the back, but it's also important to look from the side as well as axially from the top or bottom to sort of get a three-dimensional picture of what the deformity is, both clinically and imaging-wise. And I don't think we have time to go into all the details of limb deformity analysis. There's lots of good courses, and I know a lot of leaders in the field have come to India and have talked about how to do limb deformity analysis. And a lot of this has been sort of piloted by the Baltimore group along with Drs. Paley and Herzenberg. But I think in general, this is sort of the mindset of when you're looking at a patient with limb deformities, you got to answer these questions, right? Is there deformity? Where is it coming from? Is it coming from bone, soft tissues, both? Is it one deformity, single apex or multi-apical? What is the plane? Is it just in one plane, or is it multiplanar, or is it an oblique plane? Is there any translation of the bony segments? Is there any malrotation? Is there limb shortening or lengthening? So again, lots of questions, but once you sort of dissect it down and answer these in a very organized, structured fashion, I think it'll help you in the long run. And it's not just for pediatric orthopedics. I think if you're dealing with post-traumatic deformities, or if you're a limb reconstruction surgeon, this kind of algorithm is important, just to organize your thoughts and avoid missing some subtle changes. Oops. So again, it starts with getting appropriate imaging. So this is a patient who had a genu valgum on exam, and I think I showed her pictures. She was a child with nutritional rickets. So on exam, clinical exam, she had valgus, and I got the first X-ray on the left, and it didn't show the valgus. And sure enough, they didn't do the X-ray patella forward. So 5 minutes later, we get a new X-ray, and you can see the difference in the limb alignment. So I think the point is, you start by getting an appropriate X-ray before you start measuring numbers and angles. And even if, let's say you're in the operating room, you cannot get a full length standing X-ray, you can just get two separate X-rays, one for the tibia, starting from the knee to the ankle, and another for the femur. And you can measure some of these angles that we'll briefly talk about soon. So it starts with the standing X-ray and looking at the mechanical axis deviation, with the line from the center of the hip to the center of the ankle, and seeing its relationship to the knee. And usually this mechanical axis line is slightly medial to the midpoint of the knee. And instead of remembering all the different angle numbers, etc., if you just remember 87 and 90 degrees as normative values, I think that's good. And that means, like, around the knee, both the lateral distal femoral angle and the medial proximal tibial angle is about 87 degrees in adults and older children, and around 90 degrees for this lateral proximal femoral angle and lateral distal tibial angle. And you can see how these are drawn. And I'm sorry, I don't have time to go into the details, but I think a lot of you already know this. Now, what's interesting is that these are adult numbers, which honestly were not based on any scientific paper. It was based on observation, which was never quite published, at least not by the Paley group. So what we did is we looked at how these values are noted in children, and at each of the different age groups, starting from age 1 to 18. And we did 2 publications looking at these different angles. So obviously a busy slide, but the point is that you don't just use those numbers, especially let's say you have a 2-year-old child with Blount's disease and they have a lateral distal femoral angle of 100 degrees, which is varus. So you don't start correcting that varus in that 2-year-old because that's normal for that age group. So I think if at any point you're treating children under age 7, it's best to look at these age-specific normative values as opposed to adult values. And just like with, what the classic Salinius paper said, after age 7, the numbers attain adult values. So after age 7, you could just use regular adult numbers for different deformity parameters like mechanical axis deviation, LDFA, and MPTA. So again, is there malalignment? That's the first question, right? So, and again, there's malalignment and there's malorientation. Alignment refers to the entire lower limb, as we said, the mechanical axis deviation with a line drawn from the center of the hip to the center of the ankle and looking at its relationship at the knee joint. Once you've determined that, then you go into, where is it coming from? Is it coming from the femur, tibia, both? Is it coming from the soft tissues, from the knee joint? And so once you know this language and you have good x-rays, then it's very easy and very routine to sort of sort it all out very quickly. Joint line convergence angle is another sort of number that we should look at, because sometimes the bones are normal, but it's just the soft tissues around the knee where the problem is. Either you've got like a tibial plateau depression, or let's say somebody's got a posterolateral corner injury and has lateral laxity. So they're opening up and going into varus or valgus, and there perhaps correcting a bony problem is not the issue because it's a soft tissue problem. And sometimes you've got both. So I think, again, if you have a structured, organized approach to looking at limb deformities, it just translates then into doing the right operation for the right patient at the right location. And even if you find a problem, let's say in the femur, you don't just stop there. You still go through the exercise of looking at the tibia, looking at the joint line convergence angle, so you know what's normal and what's not. And if you've got a full and standing x-ray and it's a unilateral problem, you can certainly look at the other side for reference values. And if both sides are affected, then you can refer to the published normative values. Then, people talk about this good combination, bad combination, meaning like how much can you accept a joint line obliquity at the knee when you've got, let's say, distal femoral valgus and proximal tibial varus, but the two kind of offset each other. Meaning there are times when you don't have malalignment, but you could have malorientation, right? And so people talk about 5 degrees being kind of an acceptable limit of joint line obliquity. And then Cook and others suggested way back that there's a good combo and a bad combo of, knee joint obliquity. Meaning if you've got distal femoral valgus and proximal tibial varus, that creates shear forces at the knee joint. And that's much worse than having the other combination. I'm sorry, there's background noise here. Then you have compensatory translation here, and meaning you can have the same amount of angular deformities, but this is pertinent primarily for post-traumatic issues where you've got, let's say, a fracture and some angulation at the fracture site. Then the effect of that angulation at the knee joint is predicated by which way the distal fragment is translated, if it's translated medially or laterally. And of course, the same amount of angulation can have different effect at the knee joint, depending on whether it is closer to the knee or further away from the knee. So here you've got a 20-degree varus angulation, and being distal to the knee causes less issues compared to if that same angular deformity is closer to the knee. We're not going to talk so much about sagittal alignment right now, but I think it's important to at least point out that that's another factor that you should look at before you embark on surgical treatment. And again, I'm not going to go into all the details at this point, but there's like lots of courses that go into all this in more detail over multiple days. Then, you know, few words on osteotomy planning. And again, some of this is very basic, but Paley and others have pointed out nicely that, you know, the first rule is that when you're doing an osteotomy and you do it at the apex, or what's called the cora, which is the center of orientation of rotation and angulation, then you just need to do an angular correction without really translating the bony fragments, right? Meaning, you know, pictorially, if you've got an angular deformity, you can either do an opening or a closing wedge or a neutral wedge. And if all you did was cut the bone right at the apex, you can just sort of, you know, straighten out the bone without needing to move the bony fragments. Whereas if you have, okay, so here's that same patient with that physeal bar after a Blount's osteotomy. And remember, we showed you that she had a bony bar. And so in this case, we did, you know, address the deformity right at the level of the problem. And we didn't have to do any translation. We just had to lift the medial tibial plateau. The second rule is that if your osteotomy passes at a level different than where the apex is, then not only do you have to straighten out the bone, but you also have to account for that compensatory translation so that the bone is nice and straight. So this is the concept that, you know, if your angular deformity apex is here, but you're doing your osteotomy for any number of reasons. Is it soft tissue or growth plate is there, etc., that you can't do your osteotomy right at the level of the cora and you do it away from it, then not only do you have to straighten the bone in terms of angular correction, but you also have to translate the distal fragment in order to fully realign it, right? So here's an example, a child with premature physeal arrest of the right distal femur. And, you know, here, not only did we lengthen and correct his valgus, but we also laterally translated his distal fragment because the problem was at the level of the growth plate. But for obvious reasons, we didn't want to do the osteotomy at the growth plate. So you're doing your osteotomy away from the cora or the apex. So not only do you have to correct the angulation, but also have to do compensatory translation. And you can see on the far right slide that then you nicely realign the mechanical axis and the bone. Oops, did this again. Okay, what happened? Sorry. Okay, thank you. All right, so that same concept of angulation with translation can be applied at the proximal femur as well, at the hip joint. So this is a child with developmental coxa vara, and you do a varus to valgus correction. And in order to sort of minimize its effect at the knee, you also have to laterally translate the distal fragment. Same way with the ankle. This is a child with a post-traumatic physeal arrest with a varus of the left distal tibia. And because we're doing our osteotomy away from that apex, you know, you also have to then translate in order to uh, realign the mechanical axis. So the corollary to this osteotomy rule number 2 is that if you didn't do that, you're left with a translational deformity. So this was an adult patient that was sent by our joint surgeon saying they couldn't do a total knee on her because she had too much of a translational deformity. She'd had multiple surgeries in the past. When she was a child, she had Blount's disease. And you can see that she has tricompartmental arthritis, but also the varus, besides the varus deformity, she's got translational deformity of the proximal tibial shaft. And so here, our job was to just straighten out the knee so they can do, a total knee later. Um, and so you could see once you straighten out her knee, so much of translation is needed, lateral translation of the tibia, in order to just realign her axis, which was not fully corrected. And here she is 10 years later. Somehow her knee pain disappeared once we realigned her limb. And the last I heard, she still hadn't had a total knee. So a few other examples of why it's important to measure these angles. This is a child with Blount's who's got bilateral varus. The lateral distal femoral angle is not too bad. Mostly it's medial proximal tibial angle and proximal posterior tibial angle, which is, the angle that you measure on the lateral. And as we know, there's an 8 to 10 degree posterior slope of the proximal tibia. So normal PPTA is around 80 degrees. So you can see there's an issue with both varus and procurvatum of the proximal tibia, left worse than right. And here we sort of staged it, did one leg at a time, and then realigned the numbers, including the lateral view. Sometimes you don't have to do an osteotomy. Now, this was a child who still had some growth remaining. Her LDFA was a little high, meaning there was varus coming from the femur and some from the tibia. So we did and she was short on that right side. So we did a physial growth modulation of the femur and angular correction with some lengthening of the tibia to realign her limb length and mechanical axis. But sometimes when they are presenting, they've got deformities both in the femur and the tibia, and they're done growing. So in this patient, this is from many, many years ago, we did osteotomies of the femur and tibia using external fixation, but you could easily have done internal fixation, at least for the femur. Just for a second, switching to upper extremity, this is a child from 25 years ago, actually, who presented with a post-septic growth arrest with a radial club hand type deformity related to non-union with shortening of the distal radius. And you can apply the same principles of, in this case, what we decided to do was gradual correction of the soft tissues. And once that's established, then do a percutaneous, not a percutaneous, but a limited open proximal radial osteotomy with bone transport. And then, bone grafting of the docking site with reestablished. And again, not the most normal looking x-ray, but compared to where he started, he had reasonable function and appearance. Coming back to the lower extremities, you can apply these same principles for, let's say, this child who's got a post steroid-induced osteonecrosis of the proximal femur, and obviously too young for a joint replacement. But some people may just want to do a joint replacement. But here we did one of these Ilizarov hip reconstruction with kind of this zigzag deformity. And some of this is controversial. Like, does doing external fixation in this young child in some way compromise her chances of having a hip replacement at a later time? And I think that's a debate we can always have to see what the pluses and minuses are. And very quickly, just going over osteotomy techniques. Um, again, respect the soft tissues because you have to depend on the bone and the periosteum to grow normal bone. I'm not going to go into the details, but you can either do multiple drill hole osteotomies or use a jiggly saw for more precise location. Um, and then finally, how things evolved. I've showed you a lot of pictures of just using external fixation for definitive correction, but I think there are definitely techniques, and I've sort of transitioned a bit towards fixator assisted nailing and plating, meaning you still use an external fixation as a controlling device intraoperatively, but then the patient doesn't wake up with an X fix and instead has an internal fixation device. So here's where there was a combination. So the more options you have in your sort of surgical toolbox, I think there are more things you can do. So this was a child with hypophosphatemic rickets who's skeletally mature and had various deformities, had previously been treated elsewhere with growth modulation. And you can see on the right side, she's got varus coming from the femur and the tibia, and she also has procurvatum of the proximal tibia and some varus of the ankle, which was not clinically significant. Um, so lots of planning, which I can't go into all the details right now, but these were the options, right? You could do an opening wedge, closing wedge, a clamshell osteotomy, a fixator-assisted nailing for the femur. Do you go antegrade, retrograde? Do you cut the femur at one spot or two spots? And then tibial osteotomy, what do you do? Do you also correct the distal tibial varus or not? And the point is that you have to go through this mental exercise before you execute, any surgical correction. And so in this case, we just took the hardware out from our staples and did a fixator-assisted 2-level femoral osteotomy with nailing. And then did the tibial correction gradually with lengthening and biplanar correction of her proximal tibia. And this is sort of the final case, or actually the second to last case. Sad story of a young child, 11 years old, who as an infant, somebody was doing inguinal hernia repair and got her femoral nerve entrapped. And so in essence, she had a femoral nerve palsy and had a flexion deformity of the knee with weak quadriceps and a limb that was short. And she had been scheduled at another center for intramedullary lengthening of the femur. But I think what sometimes people fail to recognize is if you've got a flexion deformity to start with and a weak quadriceps and a patient who's got valgus, when you do an intramedullary lengthening, let's say with a magnetic nail, you are lengthening along the anatomic axis. So the more you lengthen, the more the mechanical axis goes into valgus. So here, I think for multiple reasons, it was not a good idea to start with femoral lengthening using an intramedullary device. And it could be a magnetic nail, it could be a lengthening over a nail. It's the same issue in terms of its effect on malalignment at the knee. So I think these were the things that we were faced with. Weak quads, it's sort of like a polio situation, right? You've got weak quads with a flexion deformity of the knee, and you've got valgus of the femur, and as we said, what to do. So here we decided to not do the lengthening first, but correct her limb deformity in terms of the valgus and the procurvatum. So we did a fixator-assisted plating, closing wedge, varus, and an extension, and with the plan of doing an intramedullary lengthening with a nail once that's healed. So just to quickly show you that, you could still have the accuracy of surgical correction with medial external fixation, just a simple monolateral fixator, to correct the angular deformity establish what you feel is a good biplanar correction, both in the AP and the lateral, and then put a plate on, and then take the X-fix off. So she's just healing her distal femur osteotomy now. Her knee is straight in terms of both AP and lateral. And then once that's done, then we'll do an antegrade femoral lengthening with a nail. And this final case is how technique has evolved. So this patient probably 7 to 8 years ago, I would have just used external fixation, span the knee for this patient with a congenitally short femur, ACL, PCL deficient, and valgus. But now we've evolved to doing it a little differently. So, the valgus is controlled. So you do this preparatory surgery where you kind of do a guided growth to correct the valgus. And I had my sports medicine partner do a extra physeal ACL reconstruction. We did a little guided growth screw for the ankle because he had a hypoplastic fibula. He actually didn't have a bad hip joint, so didn't need a pelvic osteotomy. So you do this, let him recover from this, and then you come back and he was 11, and you could do sort of a magnetic nail lengthening and still protect the knee with a brace so that it doesn't sublux, especially when the knee's in flexion. And here he is, in early consolidation and stage lengthening. So while his discrepancy is more than 5, you know, safely you can do 5 to 6 centimeters, and then the knee and other soft tissues get you in some trouble. So don't get so greedy. You do a little bit, and then you can always come back and do more lengthening later. So I think in summary, I've shown you a lot of clinical material, and I know it's a big topic, but I think these are sort of the take-home points. It always starts with a comprehensive preoperative evaluation, both clinically and imaging-wise. You still have to, despite all the evolving technology, the grounded principles of how you do an osteotomy, where you do an osteotomy, do you translate or not, all those principles will still hold despite this evolution in hardware. And, anytime you have an option of doing an osteotomy versus guided growth, most of the time you lean towards guided growth because it's a smaller procedure, quicker recovery, and it's better for the patient. So I think a well-timed guided growth for a lot of these angular deformities is still sort of my first choice, despite all these fancy osteotomies and implants. But you have to discuss it with the family. And again, when you're cutting a bone, always respect the periosteum. For the most part, don't use power tools, use multiple drill holes or just a simple osteotome or a jiggly saw. And implants do evolve over time. And while some implants will, overcome some of the problems, let's say pin site infection with X-fix versus internal, there are other issues that these newer implants can bring. So you just have to sort of keep your eyes open. And you can always, sorry, um, give patients more length. So don't get too greedy when you're lengthening. You always respect soft tissues, watch for joint subluxation at the hip and knee, especially in congenital shortenings. And I think most importantly, this is sort of the lesson I keep learning again and again, that when things aren't going well with the patient, don't just abandon it. That's the time when you buckle up and say, okay, what can I do to redeem this situation and minimize the chance of this becoming sort of a permanent long-term problem. So thank you so much.
Great. Thank you, Sanjeev, so much. That was a really wonderful exposition of a really complex topic. Take a water break, I think, before we start inundating you with some questions, because you've been talking continuously for almost half an hour. I'm sure our PGs and trainees have benefited a lot from what you have spoken today. You have really covered a large number of clinical cases. You've shown us the various techniques of pre-op planning. You've shown us very elegantly different methods of fixation, and the fact that you must have so many different aspects in your armamentarium, right, from fixators to internal fixation with plating, with rods, with magnetically growing rods, and so many other things that you have shown. So if there's any questions from the trainees, I'd also like to acknowledge that we have a few POSI members who have also logged in, and especially I can see James Sui is also online, so that's great. I don't know whether he'd like to say something, but thanks, James, for joining us. Is there any questions for Sanjeev? I don't see anything in the chat box yet. Rujuta, do you have any questions, or do you have anything else to ask Sanjeev?
Yes, some people have actually sent me on WhatsApp. Probably the PGs being a little shy, so I was just scrolling through them. Someone has asked very clearly, sir, what is your advice when there is an associated ligament laxity? Should we go in for some overcorrection? And if so, then by how many degrees?
Yeah. So, okay. So again, you have to sort of look at the individual case. But yes, there are two different principles, right? The first principle is, you take care of what the problem is. So if it's a soft tissue problem, you tackle it soft tissue wise, either by doing, and if it's an acute problem, then yeah, for the most part, you can do a primary repair or a reconstruction. And I'm assuming this is around the knee. You could also do what's called soft tissue tightening. So let's say somebody's got ligamentous laxity laterally and also has a tibial deformity. You could cut the tibia, not cut the fibula, transfix the distal tib fib joint with a syndesmotic screw, and you could sort of pull down the fibula distally that way. Or so I think the short answer is, and I'll tell you, so there's two situations which I deal with commonly. One is, let's say, a patient with achondroplasia that has laxity. And in those patients, I've seen that if you just slightly overcorrect them into valgus, their mechanical axis, they actually stop opening laterally. So I think to some degree, you could do that. But like I said, there's many different techniques. Now, what is that magnitude of overcorrection? You don't want to like overcorrect it to the point where the mechanical axis is going way beyond the center of the knee. So you do sort of a slight overcorrection, if you will. And how slight is that slight? You have to sort of measure the numbers and calculate it out. So I don't know if I've given a straight answer, but you could ask the person, whoever asked, if that's good enough. Or I could, if there's a case, I can sort it out. But I think the point is, conceptually, you could do two things. You could either address it where the problem is, either by doing a soft tissue repair or reconstruction, or at the knee, pulling down the fibula distally. But you have to be careful in children, because I've seen a case or two where that was done and the proximal fibular epiphysis was pulled off. Or, a patient develops a peroneal nerve palsy because you're pulling so hard and so much. So I think everything done in moderation is typically okay, but you just have to watch for these kind of pitfalls.
There's one more question from Dr. Amit. He says, could you elaborate on the cover-up test and indications for X-ray for bow legs?
Yeah, no, that's a good question. And for people who are not familiar with the cover-up test, it's sort of typical in a young child, let's say, 1 to 2 years toddler, where the parents come in and they say, my child is bow-legged. And then when you lay them down, their knees are straight, but their lower leg or their feet is pointing inwards. And that's typically because of internal tibial torsion. So I think what a cover-up test is, that you can demonstrate it to the family and the parents, that you just cover up their feet and say, okay, look at the knees are straight. And then you cover up the knees and then you say, okay, but the foot is pointing in. So it's just a good demonstration of where there is internal tibial torsion, which is physiologic for the most part, and it's not pathologic genu-varus. I think kids will compensate with internal tibial torsion by externally rotating their feet. And anytime you externally rotate your foot or your limb, you're going to get an appearance of more varus. And that holds true even when you're doing x-rays, right? When you do these long leg x-rays, if your foot is turned externally, you're going to get more of an appearance of varus than what's true. And vice versa, if you're too internally rotated, you're going to get an appearance that there's too much valgus. So I think that's a long-winded answer that yes, a cover-up test is good to sort out what's physiologic and what's not, and also whether there is, there's actual genu varum versus internal tibial torsion that's looking or appearing to the family that there is, varus deformity.
Thanks, Sanjeev. I can see James is online as well. James, you have something to say.
Second
So nice to
part.
have you with us today. I'm sure you have some masterful comments to make.
Alaric, second.
Yes, 1 minute. I'm just asking Dr. James Sui, who joined us from Singapore, whether he would like to say a few words. Oh, you can't unmute yourself. Huh?
Meanwhile, we can allow.
Okay, hi, thanks. Hi, Sanjeev. Yeah, thank you for really educating us as usual. Just a question on Blount's. George Rapp being our good friend and Rapp osteotomy had been there for a while. I did not see that you mentioned that. Would you think does Rapp osteotomy still has its role in young, like 6 to 8 year old, or you think that because of guided growth, we sort of abandoned that procedure?
Yeah, no, I think Rab osteotomy, and just for the trainees who may not be familiar with it, George Rapp sort of very elegantly described this oblique osteotomy, where you can correct a biplanar deformity. In Blount's, it's varus and internal tibial torsion by doing this sort of oblique, proximal to distal osteotomy just below the tibial tubercle. And depending on the obliquity of your saw cut, if it's more horizontal, you will get more rotational correction. If it's more vertical, you'll get more angular correction. And if it's just 45 degrees, you're going to get equal of, frontal and axial correction. So yeah, so James, the answer is no. I mean, I think it can still be done, but for two reasons, it's sort of not my go-to usually. And one, like you mentioned, is that, guided growth, the implants have gotten better over time. And second, is that acute tibial osteotomies in a lot of ways, it's not, in my mind, as controlled. And then once in a while you hear about issues with either compartment syndrome or injury to the tibial tubercle, et cetera, et cetera. So I think it's definitely an elegant technique, not just for Blount's, but for a lot of other times where you look at this sort of trigonometric sort of formula and say, okay, what are we going to do? But I think in general, for Blount's, acute angular correction has sort of faded away a little bit, not just for Rab osteotomy, but anything. And for two reasons. One, as I said, if it's mild enough or it's the kid's young enough, you try guided growth. And a lot of times these children, as you know, also have a little limb shortening. So, doing a Rab osteotomy or an acute correction doesn't quite give you the length. But no, and then anecdotally, even with guided growth, I've seen that once you correct the varus and perhaps even the procurvatum, if you cheat the plate and put it a little more anteriorly, the torsional component of it somehow improves or is less of an issue. So, I think, and for those reasons, I feel some of the other options may be getting more popular. What's your experience?
Yeah, you just affirmed my my point of discussion with someone else on the another webinar. But sorry, Alaric, I just take up 1 minute more of your time. You mentioned that Sajid, you mentioned about you did sort of like external device for Blount's sequentially. So you would advise most of us not to do it simultaneously if it's a bilateral adolescent bounce.
Oh, no, I think, well, I think mainly for patient comfort level, it's like if you've got this bulky device, the patient's already heavy set, a lot of them are. Um, and, sometimes even if you explain what life is going to be like in an external fixation, they don't quite understand it till they actually get it. So, yeah, in general, I don't do bilateral external fixation, especially on the same limb segment together. If it's a circular fixator, doesn't mean it cannot be done. I mean, occasionally I've done it, or let's say you could do for, I don't do that much um, sort of achondroplastic lengthening. And if I do it, then I'll a lot of times use internal fixation or lengthening nails for the femur. But I think doing, let's say, a right tibia and a left femur is okay. But I think doing two of the same limb segment bilaterally, it's quite tough for the family and the patient. But I don't know. I mean, what's your thoughts?
No, I was trying to do a systemic review on bounce and correction, and people mentioned that when it comes to bilateral, they really shy away from doing it simultaneously and rather to do it sequentially. So I just want to hear from you and the rest as well. Yeah, thank you.
Thank you so much. Thanks, James. Thanks, Sanjeev. Dr. Raj Gopal, you had a question, sir?
No, I just wanted to remind that Amit's question also had a part on X-rays. When to take the X-rays for the neural.
Oh yeah. Okay. Yeah. Sorry. I forgot about that. So yeah, X-ray. I think if you go back, you look at what's normal, right? So if let's say a 4-year-old is brought in with symmetric, moderate genu valgum, you know that that's within the normal limb alignment for a 4-year-old. Whereas if a 4-year-old is brought in with either various deformities at the knee or extreme valgus or asymmetric valgus, those would be the indications for me. So I think in general, and then you look at the entire patient, right? So if somebody's extremely short, or let's say you talked about those tibial bowing, you feel like there may be some kind of anterolateral bowing or something like that, or you see caffeole spots, then obviously, you want to do imaging. But I think in general, um, I think in like typical pediatric orthopedic practice, like somebody else mentioned about, the cover-up test. I think a lot of times when children are brought in with bow legs or knock knees, they have a physiologic problem. And, going back to sort of the earlier part of the talk, I think that's really for the trainees and the young practitioners. That is the sort of the crossroads where you just have to have enough experience and comfort level to say, I don't need to get x-rays on this patient, or yes, I should get it for this one. So I think the point is a good one. Yes, you use a cover-up test, you see the child walk, you sort of look at them 3-dimensionally, always do the torsional profile too. And in general, something we didn't talk about here, but a lot of these sort of packaging problems, including tibial torsion, clubfoot, hip dysplasia, is more on the left side. And as a matter of fact, 2 days ago, I was just watching people walk by. And if you look at even adults walk, a lot of them walk with their left foot turned in compared to the right side. So I think some of those are just observations that you sort of look at and you say, okay, well, that may be normal. But if ever in doubt, yes, get an x-ray, but don't be obligated to get an x-ray, and feel comfortable to say, no, it's not needed. And I think one last thing is, again, one of these clinical things that you don't want to have the family perceive that you didn't really look into their problem or you're ignoring them. So always offer a follow-up. Let's say you're not getting an x-ray, say, come back in 6 to 9 months, note down numbers, know that they have actually seen you document some numbers and say, okay, these are the numbers today. Let's see what happens over the next 6 to 9 months and we'll see you back. I think that's a pretty safe strategy that works well.
Yeah, thanks, Sanjeev. I think that's really great practical advice. We have really exceeded an hour already, and I know you've traveled back from India just last night, and you've had a long day. So thank you so much for spending so much of time with us in teaching us so many of these excellent concepts. I'm sure our postgraduates, trainees, and several of our POSI members also have benefited a lot from this venture. I'll ask Rujuta to give us a small vote of thanks to conclude this meeting.
So this is, I think, one of the first of its kind initiatives. I think what is important for everybody to realize, and we owe this to the JBJS classroom, that to encourage journal clubs, to encourage critical thinking at the very outset of their training is very, very important. And to learn from the master, and it, especially somebody who knows how to make it sound so simplified. What is important is to really read in between the lines and see exactly how much of correct thinking has gone into a seemingly simple outcome or a seemingly simple procedure. Remember that as a surgeon, everything that you do is all about planning. So if you fail to plan, then you're planning to fail actually. And I think that's what Sanjeev has given us, a really beautiful insight into what all things should go into thinking, not just the angles, but a lot of the clinical features that one should really keep in mind. And of course, a huge, huge thanks to IOA, a huge thanks to the IOA president, and a lot of efforts, I think, spared by the IOA to really take this to a lot of the PGs across the country. I think what is most important is to have a good bridging and open up a good dialogue between the PGs and all of us. I think that's where the more you discuss, the more you learn, and the person who actually organizes or starts a teaching program or crafts a lecture probably learns more and more by wisdom and hindsight. So I think it's a different journey, different stations in the same journey for all of us. And thank you all for joining in. And we promise that we will keep continuing this momentum and try to take you through different aspects through everything. Once again, I thank Dr. Sanjeev Sabharwal, Dr. Shiv Shankar, Dr. Naveen Thakkar, and Dr. Rajgopalan Iyer for blessing us with this wonderful opportunity, and all my colleagues and the PGs.
Thank you.
Thank you so
Very
much.
well done.
Thanks, Sanjeev, and thank you, everyone, and have a great weekend.
And
Thank you.
stay safe.
Bye.
Stay safe. Bye.
Thanks to all of you. I think, Rujuta, we would like to have Dr. Sanjeev once more after a few months or something. It's very,
Yeah,
very
I love coming to India, either physically or virtually, anytime.
It's definitely
A lot of other IOA members like Dr. Rajesh Gupta and Dr. Sumant Sinha and a few other seniors also who've tuned in just to show that how much good interest is there in this subject. Thank you so much, everyone, for supporting us.
Thank you.
Take care. Good night. Bye-bye.
Take care. Good night. Thank you.